direction of work?
So my name's Jane Fletcher and I'm the Director of Melbourne Psycho-Oncology Service, which is a private psycho-oncology service that works out of Cabrini Health, both Brighton and Malvern, and also out of Freemasons. So my primary area of interest in relation to blood cancer, I have to say I'm very interested in sexuality because I think no one talks about it, and areas where there's difficulties in relationships, because a cancer doesn't just happen to the individual who's diagnosed, it's a ripple in a pond. And because I think in blood cancers the treatment is sometimes very aggressive and a lot of focus is on the patient, that the carer support person, individual, the family, often don't realise that the emotional consequences for them are quite significant. I guess I'm going to talk about the fact that psychological services are now Medicare rebatable. And so for me, that's the biggest advancement because it actually means that people can come. Public hospitals have psycho-oncology services, but they get to see the top 5% of individuals. So they see people who are severely distressed. They get to see people who have suicidal thoughts. I have the luxury of being able to see people who perhaps have some level of distress or mild depression, but they have existential questions. Why did this happen? How do I make sense of this? How do I use this experience to change what I'm doing? And Medicare rebatable sessions actually gives people access to service. Some patients will want to learn about the disease and others won't, and we're either information seekers or information avoiders. An information seeker is going to want as much information as they possibly can. The danger is they go on the internet and they find the unhelpful information. But for others who perhaps aren't information seekers, they also need to perhaps have information, but it needs to be delivered in a way that's going to be suitable for them and at a rate that's suitable for them. Not everyone's going to want to know everything about their disease, but people do need to have some information because that will reduce their anxiety. And connecting with all of the wonderful organisations that exist is really important. The support groups that organisations like Leukaemia Foundation offer and Cancer Council offer are very important for some people, but it's also important to recognise that not everyone wants to go to a support group and it's not going to be helpful for everyone. For some people, their family is enough support, and that's okay. One of the most important things that as a health professional, it's not to judge someone else's coping strategy and trying to get everyone to do things the same way. I guess the other important resource that you have, and there's a couple of them actually, one is your GP, and your GP is a fantastic resource, and I think that the patients with good relationships with their GP, they feel comfortable, they can go and ask their GP questions, and good GPs, if they don't know, will find out the information for them as well. The other important person is your haematologist. You need to be able to utilise them in a way of asking questions, and if you don't get the answer, you keep asking the question. I will always encourage people to go in with a question list and actually turn the page around and show their haematologist the question and say, could you write that down for me? Could you spell that for me? And also, I didn't quite understand what you said. Can you say it in a different way? So I'll encourage patients to use their healthcare team to get the best possible information that they can out of their health professionals. It's an interesting thing, isn't it, about better managing emotions. And I think that means that there's a judgment on that emotions are something that we need to manage. And I guess we have to face the difficult emotions and deal with them. And I think that's probably, for me, one of the biggest things people come and work with me through is learning how to deal with, how to find a place for these emotions. The reality is that they're real and they're going to come. It's a bit like recognising that there's a field in front of you with rabbit holes and you're going to try and navigate your way around it. Every now and again your leg's going to go down a rabbit hole, and then you have the choice of whether you actually pull your leg out or you go down that rabbit hole. And one of the things about something like mindfulness meditation or cognitive behavioural therapy of getting people to think differently is that we can teach people strategies so when they do go down the rabbit hole, they've got strategies of how to pull themselves out. And I guess that's how they manage their emotions, is by recognising the strategies that are helpful. One of the really helpful things about managing emotions is not writing stories. We have a narrative, that's what's happened to us, and then we write stories. And those stories can be very powerful, and those stories can feel real, but they're not real because they haven't happened yet. And so trying to stay in the now and be mindful of writing stories is very helpful. I think sometimes it's very difficult for people when they have emotions that they're not used to having. So they're not used to perhaps waking up one morning feeling a certain way, and that idea of spiking emotions, so the emotions that come and go and they're not always there. I think one of the explaining to the people that you care about that this is how I'm feeling, and these are, I'm just in a bad mood today, or I feel really sad today. And again, trying to pull yourself out of that, trying to bring yourself back to the now, what you have control of. Because most of those emotions are driven by fear. So they're driven by the part of our brain, the amygdala, that drives that response. And we need to deal with that fear rather than pushing it away. So actually coming back to, well, this is what I'm afraid of. Is it happening now? No. So I need to move towards things that I have more control about. And that would be your thoughts. I get a lot of people come and talk about relationships, and I guess that's why I talk about this ripple in the pond, is that the diagnosis of a blood cancer doesn't just affect that person. And lots of people come in and are surprised at how their support person, their husband or wife, has actually responded. And some people find that there are people that come out of the woodwork to help them, and that other people just disappear and can't face what's happened. And that can be very difficult. I think there are big learnings that come out of a cancer experience, and some of those are about relationships that and they're so important, but some of them are going to stand up and some of them are going to not be there, and that's sometimes very hard. Other very common questions are people come and talk to me about their fears, and their fears around what might happen and what the future might hold, and how they live with uncertainty. And it's very difficult living with uncertainty, because until you've actually been told that you have a cancer diagnosis or a diagnosis of another serious medical condition, you don't know what it's like. And so for the people that we're working with, they've looked into the abyss. They have this fear now that they're going to carry forever, because they can't get rid of it. It's always going to be there, the fear that, what if my cancer comes back? What if? And one of the ways of challenging that is bringing them back to what's story and what's true. And recognising that what's true, what's facts, and recognising to stay behind that, stay in that space, rather than pushing yourself into the uncertainty of what might happen, what's story. And things that are helpful: mindfulness meditation, cognitive behavioural therapy, some other types of therapy. But what's also very helpful is bringing people back to what's important, bringing them back to joy, getting them to focus on all of the good things that are in their life. And sometimes that can be hard. Sometimes we can really struggle to find one thing. And I'll often say to people, just find one thing every day that was good and focus on that, and try and bring some more things in, but one thing. Doesn't matter what it is. And it could simply be listening to Tinkerbell laughter of children. It could be just patting the dog or the cat, or it could be just holding the door open for someone. And that can be enough to just give you some meaning in your life. We also need to remember that the time of diagnosis is a very stressful time, and that there is an acute stress response that happens. What we want to also recognise is that a small number of individuals will go on to develop more serious disorder, like post-traumatic stress disorder. Most people will have some recurrent negative thoughts about their experience, but what we're really looking for is those people who have more significant flashbacks, where they can't seem to let go of the experience, where they're finding it very emotional when they come back to the hospital. Those individuals might be well guided to go and talk to someone about that and to determine whether in fact they do have a post-traumatic stress disorder. We're recognising that probably we under-diagnose post-traumatic stress disorder in an oncology setting, and it's one of the things that I think we can do a lot about if we catch it early enough. GPs are a wonderful resource, and I think sometimes in an oncology setting what happens is that the haematologist becomes the focus of attention and the GP has a lesser role. It's very important that we're all communicating back to the GP what's actually happening, but the GP is a wonderful resource of linking you in with other services. They also can do what's called a mental health care plan, which enables you to have 10 sessions with a psychologist or a clinical social worker. And those are initially 6 sessions and then 4 on review with your GP. And that enables you to get some Medicare rebate for those sessions. And it means, again, that your GP is a conduit and linking you in with potentially other services, and they could be community health centres or, in fact, psychologists back at your local hospital. One of the other things that I think is worth mentioning is that in the last budget there was approval for Medicare-funded psychological services through telephone or Skype or some other type of technology, so that we can access, so that individuals can access psychological support from regional or even remote locations in Australia, which again is fantastic for access and giving people access to service who may not have had access to service before.